with
No,
your
you'll
immune
let me know in a
system
second.
as weak as it is, I would. Ah,
Good.
Difference between using the Cat 6C and also the Cat 5. I really would like to understand.
So volume here.
And also, what about the future movements? So actually, we are building here something for decades, for,
Make a motion to approve the agenda.
overall, I think,
So,
it's
on?
maybe a
Yep.
couple of
Volume is there.
thousands, between
Okay.
the,
Back to
the price of Cat 6C and Cat 5.
okay.
Aye.
You turn up loud. loud.
So I mean,
Volume. I need.
That should be a remote. It's not in here.
I don't think so that you guys say all if you go, that's the same, line.
Good morning. I'm Sue Norton, behavioral health manager. My stats this month may be a little bit off. This meeting was early, so I ran the reports on November 30th. So all the contacts probably wouldn't be accounted for. An example would be our psychiatrist is in on November 30th. He saw several patients and he dictates his notes after the session. They would not have been transcribed and entered into our system for them to be accounted for. So I had to run the reports earlier. So they're probably lower than what they would typically be just because of it. As far as updates, this past month we had a couple of staff that had to be quarantined due to direct exposure from contacts with our consumers and had to be quarantined, but they're all healthy. Everyone's back at work. We're still doing some remote work, but most of it we're back in the office doing our business. The biggest change that's coming about in our drug and alcohol treatment, and it's nice to see. It has to deal with Medicaid. This, I believe it was this week, we got notification from Forward Health, which is Medicaid, indicating that as of February 1st, they will now be adding AODA or alcohol and drug residential treatment as a benefit under their Medicaid. So prior to this, unless someone would have had private commercial health insurances, and even that is iffy at best whether or not they would cover it. If someone needed a higher level of care where they had to go into a residential treatment facility, it was at the county's expense 100% to get them in there. So we'd work very diligently to not have to go that route. However, there are some incidences where that's just not doable, that we can't avoid having that happen. So this will be helpful as the majority of the individuals that we see are on Medicaid, and this will offer some higher level treatment at not as high of a cost. We'll still have to pay and we'll bill the consumers for it'll be the cost for the actual treatment will be a card covered service with some hoops that the providers will have to jump through, but that's pretty typical when you're dealing with Medicaid and some of these funded programs. So that's a huge thing because that will offer some ability, perhaps, people to get a higher level of treatment that they're needing, maybe than what we would have done in the past. Prior to this, Medicaid back decided, oh well, we'll just have it as a CCS, the other program that I have, a benefit where they could cover the costs. However, it's and we call it an IMD or institution for mental disease is not an it's a non-allowable place of residence. Me and an institution of mental disease is any treatment program or inpatient program that has 16 or more beds. And what they found from that, and in my opinion, they could have found this out before they went to the extent of doing this. The majority of the facilities in the state of Wisconsin were 16 beds and over. So it really wasn't much of a benefit when you only have 2 or 3 maybe hospitals by your state. That would have been covered under the benefit. So that 2 years later, that it said it would make this a bit more restrictive. So there are ways that they can get around the IMD with this benefit. So this is a positive in our AODA world. Any questions? I don't have a whole lot to report.
Sue,
Yes.
why don't you talk about some of the commitments that have happened and kind of where they're at? Because again, those are the high dollar things that we try to plan for, but always can't plan for, which have real budgetary impacts.
Okay. So are you asking about how many commitment? And when you're saying commitments, are you saying that they're in a treatment facility
I'm talking,
or on a
I'm
commitment
talking
order?
for sure the one that's in Taylor County, but if there's a couple others that maybe needed to go to Winnebago or the like,
Sure.
especially for the newer members, these are the items that really impact the budget because these are the ones that have a much higher cost on a monthly basis.
Sure. So since I think it was last month, we talked about how we kind of budget for crisis based on past numbers, and then I discussed about where we were at in relation to our budget, and I used Winnebago Mental Health. I just got a report from Winnebago, where we were at. I think we were at. If Brian, do you remember where we at almost at our budget for 2020? I think we were. And I got a report, and there's probably at least 30 days at $1,100 that wasn't part of that we'll be paying out yet. And I still have someone there who will probably be there through the end of the year, if not into January. We were able to relocate one individual that had been there for an extended period of time to what he's referring to as Taylor County. There is a CBRF, or it's an 8-bed facility, and they have a few facilities where it's a transitional living program where they own it supervised 24/7, but it's not a locked facility like a psychiatric hospital, and they provide treatment support. The reason we went with that program is there's not a lot of programs that are like that, but also this individual is on our CCS programs. Some of that cost we're going to be able to bill Medicaid for and recoup for it for CCS, so it will be at a far lesser rate than what the being in the psychiatric hospital will be. There still will be some costs, but trying to get this individual the support that they need before entering back into the community. But those once again are things that you attempt to predict, but there are always these outliers. COVID is not friendly to people with escalation, and I would foresee more coming in the future, unfortunately.
And I'll make some comments, and Sue, if I misspeak, please correct me. The one individual that they have relocated to transitional housing was placed before, and so this move to transitional housing in Taylor County is at a lower cost. But what we're also trying to do is figure out a way that we can provide services and support, I should say support even more than services, but support and services to this client, because eventually this client will be returning to Kewaunee County, but we want to make sure that we have the skills, the supports in place that when they come back, it's hoped that we won't have to place them again. Now, we have placed this client more than once. And so these are those types of things that while we try as much as possible, because there's the human element in this, there are times that we can provide as much support and services as possible, but they still may at times decline, or there may be a crisis where we do have to place them. So those are always very difficult things to do, and the staff has to be very cognizant of this being a voluntary type of thing. Yes, we can place them, but then after a certain period of time, they will come back and we have to provide services. We cannot force certain things upon these folks. So I just wanted the committee to be aware that, yes, right now we have someone that was in Winnebago. They are now placed in this transitional program in Taylor County. They will be returning to Kewaunee County, but this more than likely will not be the last time that we have issues with this client that we'll have to address, and that's just part of the services and the requirements as to why we're here, is to help folks like this. And as Sue has said, the difficulty with COVID and the coronavirus is when you talk about quarantine, this is something that takes people out of their daily routine. And a lot of times that daily routine can be very comforting to people. And so when you prevent that from happening, that can also cause a decline in their status. Am I fair in saying that, Sue?
So what we're also doing is we're also working with law enforcement, local law enforcement, and the sheriff's department to try to collaborate on how, when people come back into with mental illness, a lot can be done in how we respond to individuals, and so we're trying to work together and figuring out best ways of response, because they're going to live here. This is their home. I wouldn't expect them to move, and we can't just have them in an institution forever. That's not that doesn't happen anymore. So we're trying to be very collaborative in how we work, and at Human Services, we are and law enforcement are the most consistent people in some of these individuals' lives. So if we can work together to figure out a plan of how to best support to try to avoid hospitalization, because those hospitalizations are meant to stabilize and out. It's not going to resolve the problem by no means. And most times you can't medicate this stuff, out of people. And so it's a lot of education and working together to try to figure out how, as a community, we can best support individuals. Because sometimes it can get frustrating, when it's kind of the same story. And so we're making lots of efforts to try to avoid and to provide hopefully a better quality of life for them. But yes, I can guarantee you this won't be the last time, um, for several of the folks that we work with. I'm also looking into collaborating possibly with Door County on some suicide prevention, suicide education. There's been an increase in the number of suicides in our county as well as in other counties, and the concern is that's only going to increase. I believe in Kewaunee County, I'm aware of 7 this year, whereas last year I believe there had been 4 completed suicides. And for a small county, that's a lot. And so we're going to look to collaborate jointly, maybe with them, see if there are joint efforts or things that we can work together on. And we're going to work with getting some information from other counties to see if they have it. Work.
Good morning.
Press the button. There you go.
There we go. So today I wanted to talk with you about Adult Protective Services, or APS. So in weeks past, I covered the 4 other programs that I oversee. So APS, Adult Protective Services. Why do we need APS? Because we believe competent adults have the right to be safe and free from abuse, neglect, and exploitation. We believe competent adults have the right to retain civil rights. We believe competent adults have the right to make decisions that do not conform with social norms as long as their decisions don't harm others. And we believe competent adults have the right to accept or refuse services. what are adult protective services? Adult protective services are those services provided to ensure the safety and well-being of elders and adults with disabilities who are in danger of being mistreated or neglected. Additionally, we assist if consumers are unable to take care of themselves or protect themselves from harm and have no one else to assist them. Interventions provided by Adult Protective Services include receiving reports of adult abuse, exploitation, or neglect, investigating the reports, case planning, monitoring, and evaluating. In addition to casework services, adult protection has to arrange for emergent needs such as medical, financial, legal, housing, or supportive services. How do we complete adult protective services? Kewaunee County's adult protective service worker is Jody Vandervest, and I'm the backup when she's off. Jody investigates reports of abuse or neglect that come in from various sources, such as internal within the agency, community partners, such as law enforcement, managed care organizations, or other concerned community members. Jody assesses the client's level of risk, and she suggests appropriate interventions. She provides crisis intervention if needed and ensures that immediate needs are met. Another key aspect is that she works to ensure clients' rights are respected. It's important to note that a fair number of referrals are received from residents who are concerned about the condition of an individual's home. If an individual is competent and chooses to live in conditions that may be less than the standard for most, it's their right to do so. There are some cases in which the condition of the home reaches a level in which it's considered to be a human health hazard. In those situations, we collaborate with public health to resolve the issue. Our APS worker also works with the courts regarding guardianship matters. The county will petition the court for guardianship if the person is in need of a guardian and if the consumer meets medical assistance guidelines. The order mandates that a comprehensive evaluation be completed prior to the guardianship hearing, as well as an annual review of the ward to ensure that guardianship continues to be needed. We also complete healthcare power of attorney documents with county residents to prevent the need for future guardianship. In 2019, there were a total of 67 APS referrals, and so far in 2020, we have received 66. In addition to APS, Jody also has a strong role in the transportation program. She assists with assessing consumers for the transportation program. Lastly, who do we serve in APS? In Adult Protective Services, we serve any Kewaunee County resident who is over the age of 18 and is in danger of being mistreated or neglected, or if they're unable to take care of themselves or protect themselves from harm. We serve residents who are young adults and have cognitive limitations. We also serve elderly who are suffering with dementia and are no longer able to care for themselves. We work with adults who were healthy up until they experienced a tragic accident, leaving them with substantial brain injuries. Furthermore, we work with healthy adults who appear to be completely competent and yet have been taken victim to financial exploitation. In sum, Adult Protective Services is a mandated program that serves consumers in a variety of capacities. In Kewaunee County and in many other counties across the state, we have seen an increase in financial exploitation cases. As our county ages, the number of referrals made to our APS unit will only grow. I am grateful for Jody's vast experience and her ability to work with our consumers in a compassionate yet firm manner. Questions about Adult Protective Services? Okay. For the other programs I gave you, I handed out an updated spreadsheet. Again, like Sue, the numbers weren't completely in when we had to submit the updates because it was earlier in the month. I'll start with the LTS, or Children's Long-Term Support, at the top of the page. Updates in that program, we managed to successfully get through the CLTS audit that I think I had talked about last month. Very little remediation was needed and there were no financial penalties. The staff did a great job preparing for that and making sure everything was organized. It was unexpected that we had a financial audit that followed the program audit, and that also went very smoothly for CLTS. Outside of the audit, we are working to eliminate the wait list for children's long-term support. All of the consumers who are currently on our wait list have been assigned to a case manager, and that will put our case managers at capacity. So I'm a bit concerned because new referrals obviously continue to come in. I have 2 that I'm in the process of assessing, and then today I will begin the assessment process for 2 more. So my concern is that because of COVID, very few people can leave the program. It's a MA rule that we don't want anybody to lose medical assistance. So even if they are no longer functionally eligible for the program, we need to continue to serve them. So again, our case managers are very near capacity, and we have more consumers coming in than leaving the program. Birth to 3, the referrals for birth to 3 statewide have been lower than usual. So we just continue status quo with birth to 3. And at the state level, DHS is working on some campaigning to draw awareness to the program. Early in 2021, we'll work on the annual program review for birth to 3. CST, we had some unused funding in CST due to COVID. So we are utilizing some of that funding for a training next week. It's a virtual training called Interviewing Child Victims with Disabilities. It'll be offered to all of our staff within the agency, and then we'll be able to use some of that unused funding to cover the cost of everybody's time and the cost of the training. I have already attended that training, and it's one of the best I've ever attended. So I'm looking forward to expanding everybody's knowledge with that training. APS, obviously, I just gave a substantial overview of the program. You'll notice in November, there was one financial exploitation case there, and the financial impact was unknown. Since submitting these numbers, it looks like that one is not going to go anywhere. It's appearing as though there's no criminal activity connected to the report. And then for transportation, things are kind of status quo there as well. We continue to run at about half capacity with both drivers and riders. And we continue with COVID protocol for the program. Scott did assist with a grant to the Greater Green Bay Community Foundation. We're hoping to get some funding to support the cost of transportation needs that are unmet through our program because of COVID. So we'll see how that rolls out. Questions for my programs at all?
Melissa, could I just add, when you're the staffing concerns, already at this time to assist, 4 of my staff also do children's waiver to help support. So to take a little bit of that load off of. So when she's talking about concerns, it's legitimate because we're already tapping into other units to provide these services. And as the wait list continues to grow and there won't be a wait list won't be allowed anymore, those individuals will have to be served. And so it's not just the few people in her unit, or my staff are also cross-trained and doing CLTS as well.
Any questions? Okay, thanks for your time.
Yeah, no, I mean, I think we'll have to talk tomorrow.
Good morning.
Morning.
So I am pretty simple here with my numbers as well. You can see they're pretty steady. The only thing I would point out to you is that kind of like last month, we had almost our highest month all year in new referrals. So this is probably our highest month since we started the pandemic. So we're trying to manage referrals and new CPS reports. Other than that, our contacts are down a little bit because since September 18th, we have been at about, well, we've been reduced by about 1.5 staff, if not 2 on a regular basis. I've had 1 person on FMLA and at least 1 staff since September 18th on COVID quarantine. So we've been sort of running a 3-ish man show since that period of time. So the contacts, I think, kind of ebb and flow with that. Foster care contacts, again, pretty steady. Those are not really a consistent thing. They don't have to be. happening on a regular basis. They happen more at some times of the year than others. And of course, we do not have a wait list. So, like I said, the biggest news for us is just trying to get to full staff, and I don't see getting to full staff. We have had one worker that was in a position with COVID, but the rest of our quarantines have been about family members or work contacts, and those result in what usually amounts to a 24-day quarantine. So that's a problem. But it is what it is. We deal with it. We have, of course, like I've been telling you, reduced our placements by the out of home placements by the end of this month. We should be down to 2, but I'll remind you, kind of like we discussed Sue's unit, this is not an exact science. We have 2 to 3 that are really in a position where they're struggling, and we're doing our best to provide in-home services and various other things. But at some point, as I pointed out with the behavioral health, it's important that at some point people, parents, children, have when we'll do best to inform when those situations happen, but they can happen, at any time. The other thing that I have been working on a little bit is we submitted for our promoting safe and stable family, as well as our targeted safety services state reimbursements or pass-throughs. Brian could probably explain this a lot better than I can, but it is one of those things Scott has talked about where we're trying not to rely on monies for budget off these various state programs or SPC codes or other things you'll hear about from Brian. So one of the things we did was with one of those, we targeted really money for respite and case management, right? So we can some reimbursement for workers' salaries, but also then providing respite, which is one of the ways we try assistance for that. And then the other one, promoting safe and stable families, we've made a bit shift to focus on parenting. I believe that if we are going to continue to keep our placements down, we have to continue to enhance services in the ways that we've talked about with CLTS and CCS, but also, excuse me, we have to target parents. There is not a great deal of training that's involved for folks when they become parents, and we have to target really how of any child, let alone an incredibly complex child, which we're coming into contact with. So I have been here, I don't know how long anymore, 15-ish, 17-ish, something like that. We have never had a parenting program. And that's been a source of frustration for myself and for my workers. And I think I can speak for Missy and Sue as well. So our plan is to transfer some of the reimbursement type money and focus on being able to reimburse for actual parenting support. That's not about a child so much as it is about what do you as a parent do. I'll say all of that and then qualify it with I've asked for that. I have no guarantee that the state is going to say, sure, that's a great idea and go ahead and we'll reimburse you for that. So I guess the moral of the story is we'll come back to you and explain that to you and talk about if we need to modify contracts or other things when they say that that's okay. And I don't really know when that'll be. I hope by the end of the year they'll let us know that. So that's what I have.
I'm just going to follow up a little bit on what Corinne is saying. And for 2021, the unit managers and I are going to have a more conversation to kind of look at and analyze and examine how we're providing our services. And I may be speaking out of turn. Is there a better way or a different way that we can do some of these things? I've had the pleasure of talking with the unit manager since taking this interim position. And I won't say I've learned it, but it's been even more confirmed for me as this. When we're talking about kids, pretty much to the child, I won't say for every child, a child is not born dysfunctional. Dysfunction comes from a variety of different factors. Some of it is traumatic events. Some of it's from the household that they live in. And so from my own standpoint, I make it more simplistic. Adults create the dysfunction for our children, not necessarily the children themselves. So when I have conversations, a lot of times when I look at uh, a child that's in child protective services, we're trying to get services for the child, but that parent and that family needs those services just as much as the child. What happens though is that right now the funding is focused on the child, and there's no funding or services necessarily focused on the parent, yet the parent is just as important, if not possibly more important than the child. And while the state doesn't necessarily provide funding for that parent, I think that we as a county need to start looking at that, because to be honest, putting some of those resources into supporting that family is both in the short as well as the long run going to be a lot cheaper than having to have Corinne and her staff come out on a Saturday morning, a Saturday at 2 o'clock in the morning, and having to take 2 or 3 kids out of the home. That's going to be a lot more expensive. So how do we organize? How do we create a system that allows us to address those issues, not just from the child standpoint, but from the family standpoint? How do we provide services from a CCS standpoint that helps us to not have to place people? There's always going to be some that we're going to have to do that. But whenever we can provide services that prevent the much higher and more acute type of services that are much more expensive, that's actually going to save us money in the long run, as well as going to save us staff time. Because when you have to place someone, there's so much more staff work that's involved than trying to provide a lot of support services. And so I want to have those types of conversations with our unit managers and see, is there a way that we can be uh, blending or supporting each other's programs? As Sue said, she already has some folks that are helping out Melissa's unit in CLTS. So I want to start looking at that and find, are there ways that we can be reprioritizing how we spend some of those dollars and provide some of those services. I don't have those answers right now, and let's be honest, the 3 people that are running their units are much more knowledgeable than I am as to how to move this and put this together. But I just wanted the committee to know that what you're hearing from the unit managers here and have heard since we've started to do these reports is that, yes, we can talk about caseloads and should talk about caseloads. Yes, we can talk about dollars and should talk about dollars, but we also need to talk about how we provide those services and support those clients, which are our residents, and how we can do it in such a way to be as effective as possible for client outcomes for those folks. And if we're doing it that way, the money should also follow in the respect that we're actually being wise stewards of the county taxpayer dollars as well. I'm sorry, I didn't mean to get off on a side standpoint, but I just wanted to, from what you're hearing that we have to start to provide a more blended type of service delivery than just have each unit do their own thing.
And
And if anyone, go ahead.
sometimes it's a gap filler in the sense of they might get someone in. When I talk about having to jump through hoops with Medicaid funded programs to get someone on the CCS program, it's a 30-day process. It's not like, oh, you're on the program, we're going to come in like white knights and save the day. It's a process because of all the required components that have to be done. So if you have someone that just comes to their attention, there's significant risk. We can try to get them on the program. It's a 30-day process, but 30 days could make or break whether they place someone or not. So sometimes having that ability and that flexibility to put someone in there in the to fill the gaps until all that gets in place, I think is crucial.
Families that are functioning, the CPF, the request is incredible. And I'm hopeful that, if they approve it, we'll be able to really those provide services. And I
May I interrupt with a question?
Sure, go
Go ahead, Rose.
The gentleman who just spoke, because of all the masks and all the hard to identify, could you identify yourself? Because I like what you said. And who was it?
Rose,
that
this
just-
is Scott Felt. You're
Yeah.
making me blush.
Well, I can't tell without a mask on. All right, Scott.
Not a problem. Thank
Yeah.
you, Rose.
I will have a hard time following that, Rose, but I think that it's just as I've been here for a bit of time, I don't always like to admit much anymore. Um,
You started when you were 16.
right, yeah, maybe 12. Let's just um, the the idea is that we've always gone away, and this is kind of the rub with human services. We've gone away from prevention. Those of us on the ground think, "Dial- here's a and sit with you without coffee and say, you know, I didn't need we try to take here and through some of those stuff. We don't know. You know, I think that the state in so many ways and other folks who fund us have away from our suck it out. And now part of what it's been a good budget process. You've heard me say that before. That helps me learn about maybe how to skin this cat a little bit, right? Is there money there? Is there money there that I can get to do this stuff? It's not your and that's just coming off the county dollars. Also, that can help, and we can. Again, one of those things. I think it's somewhat ridiculous when you say it out loud that in doing child protection justice, we have no resources for people.
And this is where, if I may, I want to go a little bit as well, because here's the concern is when you're talking about state funding and tax dollars and the like, one of the first questions comes down to what is mandated? And we know that parental support is not mandated at all. It's only, so in other words, they'll mandate or provide stuff when the crisis has already occurred. And let's be honest, for any of you that know that, that's when things are most expensive. So we as a county, and again, that's where we kind of have that, we have to be able to strike that balance is, okay, we as a county may want to, and more than likely should, fund some things that aren't necessarily mandated, but I guess I would put it more as an analogy of it's more of an insurance policy. You aren't, if we put some of this money in from a prevention standpoint, we're hoping to prevent the larger, and I don't want to use the word catastrophic, but the larger impact event happening that becomes much more expensive. Is it mandated? No, it's not mandated. But if we're doing those things right, we're trying to protect ourselves against the placement where we're pulling out. And I guess I can say it this way is at CPS, we have certain families that have multiple kids, some as much as 6. Think of what the cost would be to place 6 children out of the home if that were to happen. That would be, again, not catastrophic, but the budget impacts would be extremely significant.
And so that's going to be a face. So one of the that also say these things aren't mandated or not required. I think when you step into court, you have to complete to have a successful out of home placement order is what have you done? Have you done all that is possible to keep this from happening? There is a legal criteria there in some way, shape, or form for some preventative action when possible. Of course, emergency situations, you know, that is not as much for, for time. Some of these well. And the other thing that I want to do, like I could talk with you folks and we can talk about what we're going to do in our county and our community but also we're getting a lot of push, and I can speak again pursuing this out place, out our own that we don't have to place children out of home or use restrictive placement. And I kind of some of this applications or thing type stuff that doing, I kind of push the state a little bit too and say, okay, yeah, through 3-day conference, tell me that this stuff is like individual and informal resource. I need to, so that's what I'm doing is pushing back a little bit on great. You can talk, but are you gonna state back? Because we all agree.
And it's not mandated, but it's evidence based. So the
Correct.
research and the evidence shows that that's best practice to provide things like that. So it's not mandated, but in my world, we're required to use evidence based practices, or we should be using evidence based practices, because that's what the research and the evidence shows to be the most effective at treating a situation. Evidence based practice would be doing some of these preventative parenting programs, but it's not mandated.
So that's where I guess this is a heads up to the committee that throughout the course of 2021, it's my intention of having these conversations with the unit managers and really talking about this. And then as we start talking about this and more solidifying kind of a how we want to do service delivery in this respect, we will then be sharing that with the Human Services Committee so that way there can be more, we can answer any type of questions that you may have. So that way you're understanding from a department standpoint why we believe this is the best path to go down.
Longer preview than I intended. Any questions?
That's my fault.
We all set. All right.
And so we should not be building the first floor out and then not being able to go building up and striving to using that space as the best we can. On paper, we are an integration, we've got enough collaboration space, and we've got enough seats. And he was comfortable with it. So,
Look, I have one question on OPEC.
Morning.
How much was Amazon
I will go through the financial package with you.
workshops like we had with all the pure
Been said before, but all our reports done a little bit earlier, get it out to you. At or third is what we bill out for insurance and paid for our workers and contracted providers. And normally this runs about 33% of our November. Month as of the 7th of 160,000. Last November at the time we had are below billed far, and the year to date of 2,188,000. Put the estimated year end of about 360 last year, probably about $99,000 short at 65-75%. Get back in money, so that's roughly $5,000 to $70,000 short on what we get back. That's basically five our staff. Any questions on it is important that the other main reports we do get about 34% of our revenues through there. And this get from state programs offered by DHS and DCF. Looking at cards, so far we're making $1,188,000 through October. We still are. We will be working on November. Got 1,188 of about 953,000 offered through the DHS. So we billed for more than that program build. Some are still working on. So.
So Brian, when you say that we've claimed, I'm just going to call it 1.2 million and 953 is offered. 953 is the total amount the state is willing to give us. Is that what you mean by offered?
In different pockets. So
nope, that's fine.
Shift it around to the right pocket. Make it all.
Yep.
Make it a little.
Just to provide a little clarification to that one, folks, I don't want it to be misinterpreted. When you said that shortage of the $75,000 or $80,000 due to COVID and internal staff and external providers not being able to provide services, I can tell you I could probably account for that $75,000 in our CCS program through contracted providers. When COVID came, all their youth services stopped, meaning then we couldn't bill for those services, as well as some of their group services stopped. That's probably that chunk of money that's the difference. I would hesitate to say it's internal staff because internal staff kept business going despite COVID.
Yes, you're right. I would say I would agree with you, Sue. And to offset that, we did not get billed for them, so our expenses were also lower for it too.
Yes.
So it's not like we're gonna revenue and expense. We've received. Actually, we've received on your report. It says that CARS report received 506,000. We've actually received 826,000, of which we've had to have 167 withheld for CLTS match, and another 23 our Winnebago expenses for residential treatment. That 826 last year was at 826, so we're pretty much the same amount of revenue that we would have received last year. Parks, we have 125,000, and we have 638,000. So we're about percent of what we billed out. And compared to last year, we had received in 573,000. So we have received in about 65,000 more. And partially that's because the BCA for the DCF has been increased for 2020 by about $100,000, which has helped. Looking at maintenance, and we've maxed out all our federal funds, so we'll be receiving 50% of what we claim for the rest of the year. So we've claimed 258,000 so far, and we have received 180,000. So for the next few months, we will kind of be receiving 50% of what we in that area.
So Brian, the big question probably comes down to this. Of all the state aid that is being provided to the county, are we going to be able to claim all of it?
I'm going to say we'll never claim all of it, 100%, but we get pretty close. Can't claim it. So you $110,000, and I only have $8,000 worth. I can only get
And I think that's the only concern that some would have is that
So, I mean,
we may not get to 100%, but we're pretty darn close, which again is just wanting to demonstrate that we try as best as possible to claim every single dollar of state and federal aid that we can.
right, and this is the time of year kind of going through to double check everything that we can get out, we can, we're getting all our money that we possibly can. The next thing I have is contract status report. Any questions on that? It's pretty straightforward. We have here we're much under budget on all contracts, so that's kind of been good. And we will have a number of 2021 contracts for 2020. Looking at the vendor, we're back to normal, 56,000 for the month, kind of our average. Out. The only thing of note on here, for a van, Melissa Transportation Unit was awarded, are allowed to buy a van this year, or next year, actually, it's in the budget for 2021. Our down payment, our match of 20% towards the van, which was $9,823. And the state will be paying the other, expect delivery 2021, probably or so. And just the $9,000 was not, did not have a financial impact on the financial statements. It's been put on the balance sheet as a prepaid. So we won't there until we actually receive the delivery of the van. The other thing, because of the meeting being quicker, I didn't have a chance to get the credit card receipts or in. So next meeting I'll have November and December. And now to go financial report for the month of October. Again, these are the actual and accrued revenues and expenses where we are as of October year end or October. And 10 months, we have 88 or 83.3 budget here. So doing kind of the main unit totals and administrative, we had revenues of 1.2 million. Good. Expenses, we were running under by 1,000. We've had 468,000 in expenses compared to 520, and that is mainly because we have not had a director since March. So, economic support, we have had revenues of 234,000 compared to 269, so we are under a little bit there, and expenses are 214,000 compared to 218. So we're pretty close there, and we're back up to full staff, so our expenses should be normal the rest of the month. Children, families in total, we've had revenues of 229,000, and that's compared to 104,000 budget. We're over really good there by 5,000, and again, that's one area where we've received most of our funding already. So the funding won't go greatly throughout the year. And expenses are at 694,000 compared to where we should be for 827. Again, doing good in that area as far as controlling expenses and knock on wood with placements. Behavioral health, our revenues are at 1.4 million compared to 1.461. So we're a little bit under on the revenues at this point. The expenses at 1.8 compared to 1.7, so our expenses are a little bit higher. Again, not gonna compare. And communities, Melissa's unit, that is revenues of 856,000 compared to 897, so we're under revenues of 534. Expenses, we are at 1.291 compared to 1.265, so we're have a little bit over expenses there by 26,000, so we're in line. But when we get down to the bottom of everything, if we were to stop everything at a $15,000 deposit bottom line, and with our goal per month 80.33 of for October, our revenues came in above that at 91.3, and our expenses are under it for 81.8. Tracking should be at a couple 100,000 for probably losses or November, December. I feel we'll definitely be at the 100 to 200, possibly more. Here in
We talked about these commitments that were out of budget or unexpected. Where will those hit and how will that impact the end result? Or has that been taken into account with what you were just
I
saying?
do what I know of. I have. So, for instance, there's a Winnebago invoice that we haven't been charged for. That's 50,000's been built into here.
Okay.
I haven't built in anything beyond October. So when I say, depending on what happens in that area, we're good if we, but it could, it won't get, I don't see it getting, way more than, especially Sue said how many people are in there, at the most $1,000 each month. But we also haven't received any money back. So when they collect money from MA or from insurances, we'll see that usually there's a 2 to 3 month lag. We've had in the past months where we've been charged $70,000 for Winnebago in a month, only to get a report in January that they're sending us back 50,000. So that's the unknown. I don't know what could still be coming back, and we're trying to.
So what you said is you've projected through October, but you haven't projected costs
For this
for
report,
the
it's
rest of the
through
year?
October where we are as of October.
Okay,
I'm not putting in, well, we could have expenses for, I'm not doing a pro forma ahead.
but you are with the last statement you made around, you think you'll end up with a couple
Surplus,
hundred,
right.
surplus.
A surplus, and that's
Now-
on the conservative side.
Right, so my question is simply that when you are projecting that surplus, are you also taking into account what program manager said about likely having
Yeah.
those people stay committed through the end of the year?
Yeah.
Okay,
And that's why I'm being very conservative. It could be better
And
being in this.
the individual that's there that will be there through the end of the year, that's the one I believe it talks about with institutional Medicaid. So if it's roughly $1,100 a day, 30 days, whatever that math is, we'll get 60% of that back from a Medicaid reimbursement. So it's not going to cost us the whole amount. It will cost us about 40% of that.
I think the important part that we're looking at here is this. I would be lying if I didn't say I was pleased with what I see as the projection for the year end from a financial standpoint. And I really have to give credit to the unit managers and Brian and that we've really tried to focus on, and especially really tried to focus on the financials and the revenue side. And the other reason why I'm extremely pleased is this has all been done in the tumultuous time of a pandemic and trying to provide service and trying to do the job while being quarantined or not being able to see clients face to face or any of those types of things. So to me, that's a real testament to the staff and being able to get the job done. I also want to throw in one more thing here. We have not discussed, nor is it part of this budget, the upcoming WIMCR payment that we'll get. So that WIMCR payment will go directly towards the fund balance, which is what we've tried to institute in the last couple years anyways, of not having that be part of the budget, as well as being able to address the fund balance deficit. So I'm really happy with what we've been able to achieve so far. Hopefully there are no big surprises that come in the month of December. Again, I want to remind the committee that we will still have expenses and revenues, more likely the revenues coming in 2021 for year 2020. But at least for right now, the picture looks very good. And again, I really want to commend the staff for what they've been able to do.
Yes, sir.
So my question probably is not about this year's budget, but next year's budget. And with all the stuff that was going on, I didn't have a chance to ask this before, but we have this CLTS will be moving to no wait list, and then we are stretched on staffing already. What is the, as we try to deal with that next year, what are the tools we're going to use to both pay for it and get the staffing to handle that load?
I think the biggest unknown that I have right now, or the big question mark that I have right now, does deal with the CLTS program. With the state requiring that there be no more waiting lists, how will they go about funding that? How will they go about allocating those dollars? And correct me if I'm wrong, any of the unit managers, what the state says they'll do and what they necessarily do are not always the same. So I get a little concerned as to, they say they will do funding. Well, how soon would we get the funding? Those types of things. Yes, I see Melissa going there. And so that's my biggest concern, is in that respect. But we'll continue to try to chart the path otherwise from a funding standpoint. But go ahead on CLTS, Melissa.
So Scott is right that historically there has been the concern that DHS makes these mandates, asks counties to follow through on these things, and then doesn't support with the funding. That has been the case for the last year and a half. There's been a push to eliminate the wait list. They provided spreadsheets, guidance on how to eliminate, guidance on remove this many this month, and by the end you should be at zero. But there wasn't formal documentation indicating that there was going to be support to do so. So we've kind of put the brakes on things. However, the funding is now there. Everything is in writing from DHS that these consumers will be 100% supported. All of their services will be funded 100%, and we will receive case management to support the cost of the staff. So our case management rate was just recently approved at an increased rate. Brian, is it 127? It's a substantial rate that we're getting for case management per hour. So I am hopeful. Again, I look at things conservatively, and I've always been reluctant to make this leap, but I'm at that point where I feel that CLTS will be well supported by DHS beginning in 2021. As far as what we're going to do with the consumers on the wait list that need to be served, and then the consumers that will be coming into our door to be served, it's going to be a pretty quick turnaround. DHS is authorizing 300 kids each month to be served across the state. So essentially, it looks like it'll be a turnaround of about a month. So a consumer comes into the door, is added to the statewide wait list, not the county wait list anymore. And then DHS within 30 days will say, Kewaunee County, you need to serve this consumer, and you have another 30 days to do it, or you'll be in non-compliance. So I am hopeful that we'll be able to have a churn in which kids will age out, and we'll be able to continue to bring new kids in. I'm afraid it's not going to be an even churn, though. I think that there will be a backup, especially with COVID restrictions. One other tool that we're utilizing is we're having our birth to 3 case manager learn CLTS. So as I had mentioned, CLTS referrals have been down since COVID. We're not exactly sure why. I think because consumers haven't been going to the doctor as regularly
You
as
mean
they have
birth to
been.
3 referrals, not CLTS.
Yes, sorry, birth to 3 referrals have been down across the state. Thank you, Sue. Because again, most of our referrals for birth to 3 are coming through the medical field. So if kids aren't getting to their regular well check visits, doctors aren't making those referrals to birth to 3. So with those numbers down a little bit, Carol, our birth to 3 coordinator, is learning CLTS. It's trauma informed to do that anyway, and it helps financially because the reimbursement for CLTS is much greater than birth to 3. So it's a smart decision all around, but that does free up a little bit of an opportunity there to have some of our CLTS consumers served by our birth to 3 coordinator. Yes.
But from a staffing standpoint, what are the various options you have if it sounds like you're going to use staffing we currently have, but at some point, if that is more than you can handle, what do you do?
Historically, we have explored contracting with outside providers, but we still need approval to move forward with that process. And I'm unsure at this point of whether or not approval would be received.
Now, if we made that request, it's covered, it wouldn't come out of, I mean, you said it's covered at 120%. Is that meant to cover our
100%.
100%? Okay. So it's meant to cover our costs plus, okay, so it doesn't impact the budget then if you
It's
do
not
that?
supposed to.
Okay.
Historically, like I said, it wasn't as black and white as it appears to be at this point. So it is my hope that that will be the case, that there should not be a financial obligation to our county. Brian, from a financial standpoint, has been sitting in on these same meetings because there is reluctance, especially for some of the more conservative counties like ours, to make this leap. But like I said, they've been really reluctant to put anything in writing until just recently, in which we now have documentation of how this will all look financially.
So do we have, like in that list of contracts, do we make a contract to those service providers where we can very quickly get the extra resources, or is it not that simple?
No, it would, you mean for case management?
Yeah, if we have for the CLTS having no wait list, if that demand comes and we don't have enough staff to.
I would
provide.
lean to Scott for that. So essentially case management is provided by county staff. And then as you recall, there was the push to make that contracted case manager a county position, and that got pulled from the budget. So that's another big fear of mine. I just want to put that out there. If I lose a staff member, it's going to cause a lot of issue because our current consumers that are being served will lose their case manager and will be stuck. So as far as what to do in the future to if we need another case manager, historically we have, because it's been so difficult to get a county position, we've looked at the contracted position, which again, there's reluctance to do that because there's such high turnover with those contracted positions. And I'm not even sure we could get that approved though.
Well, what I would, Supervisor Baker, so what we currently have right now is we have contracts with private providers right now in the CLTS program. So if we were to need to increase the amount of private provider what we would do then is amend the contract for additional money to bring those folks in. And again, the hope would be is that the state funds would therefore help to reimburse for that cost.
So I think we're talking about two different things though. There's the case management and then there's the services outside of case management. So the daily living skills, the mentoring, the supportive home care, the respite. We have providers for those. Again, because of COVID, there's been some struggles to actually get those services in place. But I think that the providers post-COVID will get back on track and be able to support those needs. It's the case management specifically that I'm most concerned about.
And when you say difficulty or reluctance to bring on additional contracted case management, is that because of what work it imposes on your departments, or is that really because you're afraid, or it's a concern that the board won't allow it?
I can try and fill in if I do it correctly. The concern comes to turnover. whether it's CCS, whether it's CLTS, whether it's CPS. When we're talking about clients, and the data is there to show this, is that when you're trying to provide services to a client, they like to continue to work with one case manager, with one provider, the like. As you start to have that turnover, that has an effect on the client outcome. And so I think what the concern is that if we have a private contractor, we know that the turnover, the employee turnover in the private provider standpoint world is much more likely than at a county standpoint. When we get a case manager in the county, for the most part, they stay for a significant period of time. When it's a private sector, you have a lot more turnover, where that case manager may move to a different county, may move to a different agency or the like. And that then has some definite effects upon client outcomes, because that case manager or provider has built that relationship with that client. And so the concern that I believe Melissa has is that, especially what we have here, is you have a number of folks that, okay, yes, we have a contract that the case manager gets paid roughly the same as a county employee, but that private employer does not provide the same benefits that the county does. And because of this new mandate from the state, you're going to see increases in need of those services, probably to, if not most, if not all counties, especially in Brown County and the like. So there is definitely going to be a need for those case managers, which will more than likely lead to Brown County and some of the neighboring counties looking to hire county case managers. So for a case manager in Kewaunee County that is a privately contracted employee, they can go to Brown County or Manitowoc or Marinette, or pick your county, and they could therefore take a position as a county position and receive those county benefits in retirement and health insurance, and get paid roughly the same, if not a little more, than what Kewaunee pays. And now we've lost that case manager, which means we've also lost that relationship between the case manager and those clients, as well as the lost time of trying to recruit that case manager to fill that in. Am I on board, or am I on target with what I'm saying?
I'll give you a concrete example. We just had one of my, because I have 3 of those contracted staff in my unit. We had a committee meeting for one of our programs, and one of the consumers there was talking about the turnover and how that struggle. And his goal for that committee was to figure out how to keep case managers around. You're in a program for 5 years and you end up with 7 or 8 different case managers. It's pretty difficult to share your life story with all those 7, 8 people. And I think of the one position I have, well, I have 3 of them. In less than 1 year, that's been a revolving door. I have my 4th person in that position. And it's also a cost to hire them. They just go on to bigger and better things. When you have a family that needs health insurance and you were offered only health insurance for yourself, but you have kids, how do you stay in a job that you can't provide health insurance for your family? Those are the revolving door positions, no
And
doubt.
it's also important to note the cost associated with training these staff. Waiver and CCS are highly complex programs. It takes about a year, if not even more, to get somebody fully trained in those programs and to be billing at a rate in which they're bringing in enough to support the cost of their position. And once they're fully trained, they're all the more appealing to those surrounding counties that need to hire. So there's lots of factors. Of course, it's best practice for the consumers we're serving, but when we, of course, look at the financial impact as well, it's important to note the concerns there.
And, this is something I've heard before, and I'm fully sympathetic to it, but we are in a position where that request for the county position has been rejected. And what I've just heard is there's some real impacts, and it's monetary as well. And I would advise this group to come up with the actual financial impacts of retraining somebody every time, the cost of recruiting, because those are real costs. And those go to defray the extra cost of having that a county position. And unfortunately, those were not brought up side by side with the extra benefits. So they definitely have a benefit by not having to do that if we can retain those people. I think that's what we need next budget to say this is
That was a
not an extra
right.
cost. This is
That is
actually
a
maybe a savings.
that is a shortcoming on my end, Supervisor Baker. And for the next budget, what I'd like to do is not only talk about the training costs, but then also, and we can't do it by specific client, but we can start to show the data as to how client outcomes are affected when we have turnover in case managers. And so, yes, in fact, from the additional expense, I'll say it this way, or additional investment of roughly $17,000 and change for a contracted person to become a county employee. Uh, Here's what we need to, yes, do the training costs, but then also just talk about the retention and how that really helps to have positive impacts on client outcomes, because we do not have clients having musical case managers where they're going from one to the next to the next. So that was the shortcoming on my standpoint, which we will address at the next budget session.
Yeah, and I think that, when you have somebody on the county staff working to recruit somebody, that's non-billable hours, I assume. If we're trying to find another case manager.
Well, we are still be able to bill them even as private contractors. We can
No,
use.
well, we're trying to fill a
Oh,
position that is just
I
been vacated.
apologize. Yes, yes,
And that's a lost revenue as well.
correct.
I think we have to be as creative as possible in assigning dollars to those things we do over and over again, which we all feel is a waste of our staff effort.
And that's where, again, it was a shortcoming on my standpoint. I tried to do it from a verbal standpoint of trying to do this in a methodical standpoint. I think there was some concern from some county board members is that I was trying to do this one position at a time to kind of step this in the transition. I think some of the county board members focused on the full uh, five positions that would possibly be transitioned. And there was a feeling, therefore, that this was something that the budget could not handle. And again, that's why I was trying to phase this in. But again, a lack of explanation and education on my part.
If I could just add one more thing, it was quite an experience to go through this process of attempting to get this into the budget. But what I heard several times was that our county board does not want to grow government. We want to shrink it. So I will work with Scott and others to bring the information that's been requested, but I really hope that we can collaborate together and that I can provide the information, or we can provide the information to you to help expand your knowledge base to all be on the same page. But when it comes to working with other county board members, I'm going to hope that I will have your support to explain the importance of why these positions need to happen. Does that make sense?
Jeff, can you attest to how legal this is, to be honest with you? I think of, we house them here, they use everything here, we pay for their liability insurance, we cover everything, we supervise them. Where's the legality with that?
I mean, it's perfectly legal. And I've said this at meetings before that, should some lawsuit arise where an employee or a contracted individual claims that, they should have been provided some county benefit or unemployment insurance, so on and so forth, we would probably prevail. And the reason we'd probably prevail is because we do have a contract with an agency, so there is that clear separation. But I will tell you, it's paper thin separation. They have a county office, they have a county phone, they have a computer, they're effectively supervised by county staff. I would say we'd probably win, but we could very well lose as well. But that would mean, for instance, if they felt they were due some unemployment insurance, the big one would be is if they felt they were wronged out of some state retirement or health insurance or something like that. Those could be some. Um, but like I said, we would probably prevail, and I think I've said at committee meetings before that when you contracted employees make sense, in particular when you have those contracted, they're providing a service. Um, but when they're effectively acting as a county employee, you 40-hour employee day to day, have an office, a phone, a computer, that should be a county employee in my view. Um, but I'm the attorney, and that's just my view on it.
In the private sector, those things you mentioned we are viewed much more conservatively, and we say that's a no-no. They can't be supervised by, like in this case, they cannot be supervised by a county employee. They can't share offices with other county employees. It's very clear separation for the very risk that had been brought up around co-employment. So we may be skating as a county, skating on thinner ice than you're actually portraying it.
Right. And when you have a professional like our psychiatrists or psychologists, those are professional employees who can have gainful employment elsewhere. I don't have a problem with those. Or those specialized services that are, if they're actually providing the service, like for the elders, they probably foot care service, or if they're providing some very specific program service, those are fine because they have a trade, they provide a service. But for those particular, I really think the county take a hard look, finding a way to make them employees. That's just my thought on it.
But the counter to that is that it's the way that they are treated as contractors. And there are methods which we could change to make it 100% legit.
We could.
That does not, I don't think the county board's going to want to have them, held up with that particular reason. I think it's going to be a lot easier to justify it on the basis of financials. And I think there's a really good case for that. I just want to see the numbers when you start talking about the turnover and the repeated time spent training people on how this county works with this in these departments, how much time we spend interviewing and looking for other people. That's all lost effort. And that may very quickly offset the difference, which is the benefits.
And we'll put that together, like I said, for when we do next year's budget for 2022. So thank you, Supervisor Baker. Yep, you have a sheet in front of you that has the amended contracts for 2020 as well as the contract for 2021. We would need, again, the recommendation from administration is for the approval of these contracts.
A question about some of these that are fairly far away, like we have something in Waukesha. Is that basically these are all the closest provider we can find? Is that what it is?
What's the place in
Bright
Waukesha?
Star,
I'm sorry.
Bright Star is the one that Supervisor Baker's talking about. That is
Dousman, Wisconsin. There's also one there.
So from the waiver standpoint, the Waukesha one is mine. Bright Star is connected to waiver. So we have a consumer who was residing in Kewaunee County, moved to Waukesha County. They have a substantial wait list. So the consumer, when they move, gets added to Waukesha's wait list. We are responsible to continue to serve them until they reach the top of their wait list.
And again, that is state requirement.
Sure. Okay. And the one for Dousman as well? Genesee Community Services?
That's Genesee Community Services.
Well, same child.
Yep.
Same. Okay. Got it. Okay. That makes sense. I just was curious why they were far away. Another one here, Lafayette, Louisiana.
Let me just make sure. Almost personal.
Family.
Almost Family is also waiver. It's a provider, I think, probably originating from that area, but serving us locally.
And some of this where you see the city, that may be where they're headquartered, not specifically that is where the service is being provided from.
Okay.
Because if you look at Olivieri Lorenzo, 6 months, Florida, that is our psychiatrist that is done through telehealth. And so, yes, they may be actually located in Florida, but the service is provided here
Sure.
through telehealth.
Okay.
And Denmark is not the country.
That would be really far away.
What does DLS stand for?
I missed it. What was it?
DLS, what does it stand for?
Daily living skills, but I would like to see it in context to make sure that's the correct acronym.
Yeah, that's probably right. It's community services, it's Door County YMCA. So yes, I would think that it's daily living skill.
Okay.
Make motion to approve contract. Aye.
Kath, why don't you come up here and Jeff, if while she's walking up, if you could give just a short introduction or background, please. Okay. Kathy, I'll let you do that. I apologize. I just knew that they contacted the attorney, so I'll let you go.
Okay, no problem. I'm Kathy Lee. I'm the director of the ADRC of the Lakeshore, which serves both Kewaunee and Manitowoc. So, a number of years ago, when we didn't have ADRCs, we had a commission on aging that served our aging unit. ADRCs came into play. There were we put up one ADRC, and if your aging unit was separate from your ADRC, then you had to have one and it merged our and in both counties in 2011. But the state allowed single county agencies by the board at that time. So even though we're fully integrated with ADRC, we still and an ADRC. But both of these committees is made up of board members from both counties, and then both counties that represent. So in April of this year, it was an oversight that regional models weren't allowed to do this. So in April of this year, this was corrected legislatively. So these provisions in the boards are, the makeup is dictated by the Elders Act. That merged it. They're very interesting. We integrated ADRC. We hold the Commission of Aging meeting at the same day, an hour before the ADRC board. Some of the members are the same on both boards. And we don't look at aging different. There's a lot of redundancy between the two meetings. We talk about a lot of the same things. What we're doing is streamlining this. We have specific, we have to fill specific situations on board. We have to have 4 members that represent older adults, and that goes to the Commission on Aging portion. Have somebody who represents developmentally disabled, and then we have 4 county board members, and they would be split evenly between the 2 counties. So this was brought to our that. Now we're proceeding forward. This through both counties. So Black County is putting it on their ADR, their county board agenda next week. And I'm contact with Jeff.
So the intention is that we would basically just consolidate both the ADRC board and the Council on Aging board. If this committee therefore approves that recommendation, it would go to the county board for next Tuesday for final approval as well. I guess the big question, and I think Kathy's already asked it, but I'll kind of ask it for otherwise, is what impact does this have on any type of providing of services or programming?
It has absolutely no impact on service provision. It will have some financial impact because we won't have as many people on the board and paying. Although we're meeting virtually this year, so we've had very little.
And I wanted Kathy to say that is, again, from my understanding, from a programmatic standpoint, especially from a client standpoint, the consolidation of these two governance entities has no effect on how services are provided to clients. Instead, it just makes the whole governance issue much cleaner and easier because, as Kathy had said, the items that are discussed at both meetings, many of them are the same, so it really takes away that redundancy and makes things easier and more efficient.
I'm sorry, I'm just a little confused about what we're combining. Do we already have a ADRC combined between Manitowoc and Kewaunee County and now this?
Yes, yes,
Yes,
yes.
what happens is what we're
bringing
talking.
all four? I mean,
So think of it this way, Supervisor Baker. Right now, you have a council on aging that oversees the the services in both, and you
they're
have
combined already.
and you have yes. So the services are already combined where Kathy's group provides services for both those clients in both Kewaunee and Manitowoc counties.
Yep.
It's just you now have two oversight groups. One is the Council of Aging, one is the ADRC board. And part of the reason why is because state statute did not allow
Yep.
for those organizations otherwise. So now what we're doing is we're doing the
those
same
together.
thing as if it was one county and allowing there to be just one oversight committee as opposed to two. Is that a fair assessment?
Yes, yes. And we also go to the respective county boards as well. So, board,
And the grant.
board on both of these committees now. And
Did we at one time have our own ADRC just for our own county? And then it's, or was it from the inception, they were always combined?
you had your own aging unit. You never had your own ADRC. So when the ADRC came about, we merged that time. And then that and merged the aging units together.
Okay, and so now we're going to complete that and merge them all into one big.
Yeah,
Okay.
and we would have done this
Except for
originally,
the-
but we couldn't.
Sure. And that's all we're being asked to approve, right?
Correct.
And the only thing that was left out was the transportation part of aging. That was always kept in Kewaunee County and not put in the ADRC. I don't know why. I think it was like some kind of issue with the money grant. But anyway, that one little segment of the aging was always kept separate.
There's actually two things, APS and transportation. Kewaunee County retained those two things within their services department.
Yeah, yeah.
Is combined.
So the way we deploy services and pay for them will remain unchanged. The only financial impact is that there'll be maybe fewer people total involved in those boards.
We save a few bucks on per diems and travel.
That's it.
So we won't have to go to Manitowoc for a meeting.
Right.
And then the other thing that we do is we have, when we meet in person, we all sites. So one month it's Manitowoc, 1 month it's in Kewaunee. But we've been meeting virtually since COVID.
But that won't change once,
No.
okay.
No, everything will stay the same. Once we can get back to normal, we want to meet in person again.
So again, from an administrative standpoint, we recommend approving or recommending to the board adoption of this request.
Yeah.
This a yearly contract?
Automatic renews year to year, so We had an original agreement, Steve Rollins, Attorney Steve. Rollins. I hammered that thing out years ago, and it just automatically renews year to year. And did look through the agreements; they're basically the same except for the governance model. So we're good to go.
I thought contract said it was a yearly.
Yeah, it's 1 year term, but then it automatically renews.
Okay, thank you.
And then if vision says he is not happy, there's a model to move yourself.
Another, have there been any objections raised to this?
No.
None that I've been made aware of.
How it originally grew out, it grew out of the ADRC really. At that time, that grew out of family care. You needed to have the ADRC. Well, this was a new thing. And I think at the time they were pushing for some regionalization or at least partnership with your neighbors. So we partnered and created the ADRC, seemed to work well enough. So why don't we start our older Americans programs? Said we retain that, which I think has worked well. We can handle our elder population locally with our protective service. And I don't know, I can't speak to the transportation piece. I don't know why. So, but anyway, the ADRC worked really well. We merged the Older Americans Act program as well. We have 2 agreements on it, and now basically instead of having 2 governing boards for these 2 programs, we're going to have 1 governing board.
And that's the main thing, is right now we have 2 governing boards, and the reason why we have 2 governing boards is because state statute did not allow us, when we first did this, to allow us to have 1 governing board. Now state statute does allow us to have 1 governing board, so we recommend to go to 1 governing board as opposed to 2.
And these 2 programs that we currently keep separate will stay separate.
Correct. Again, from a program delivery standpoint, client standpoint, nothing changes. We just go from 2 governing boards to 1 governing board.
I make a motion to approve the combination of the boards together. Aye.
Thank you, Kath. No, because we weren't sure how it was going to go yet. Yeah, but that's fine. I had done a number of commentary during the unit manager reports, so I only have one other item that I want to make the committee aware of. Again, I've been, as we've seen from the financial standpoint, we've been able to do some really good things in 2020, both from being able to provide services to our clients during a pandemic and still keep our financial books in order. So I'm really happy about that. I had also commented to the committee that we would start talking about service delivery and how we may want to adjust that or really determine how we want to move forward with that. In that same respect, I have been the interim director for roughly 8 months. It'll be 9 months probably by the end of the year. I would like to make the committee aware that starting sometime in the first quarter of 2021, I would like to start the recruitment of a human services director. While this has been very educational and it's really given me a good appreciation of the professionalism and the skills of our unit managers as well as our staff. And we've been able to do some good things. Because I am also the county administrator, I cannot provide the amount of time and attention that is truly needed in a department like human services. Again, this is a testament to the unit managers in the respect that, yes, we have been muddling through, and yes, the unit managers have taken on an expanded role, which as interim director, I have kind of wanted to have happen anyways. Part of the reason why is because I do believe they have the ability and I want them to focus on some of those larger aspects, which they have been able to do. But in that same respect, I cannot provide them from a human services standpoint the type of support that the department needs and that the unit managers need. And so sometime shortly after 2021, I want to start the recruitment. The other reason why I would like to look at the recruiting of a human services director is because as we start to have discussions about uh, service provision to clients and the structure of that, I think it's also very important that human services director be part of those discussions as well. So that way, when I finally do step away, there is consensus among both unit managers and human services director as to what is the path forward and how to move forward. Uh, if you're asking me a specific date, I don't have a specific date, but I would say no later than February is when I would like to at least start the recruitment. I would like to, for my own peace of mind, I would like to kind of see where we are from a year-end standpoint, as well as make sure that the financial changes that we tried to make are in place, and that then we can start to have those discussions, and a human services director can be part of those discussions as well. So that was the only real item that I had. I do want to thank this committee for indulging me in the opportunity to play human services director for 9 months. And I'm that is firmly tongue in cheek. This is not a game, but it does give me a much greater impression as to and greater understanding as to what this department does and how we can work together to not only address issues that the county board and that our resident taxpayers may have, but also what clients and programs have. So if there's any questions, I am open. Well, that would be the third Thursday, so that's what we usually do unless there is some issue with the committee.
I'll make a motion to adjourn.
A second?
All in favor?
Aye.
Aye.
Opposed? We are adjourned.
Happy holidays, everyone.
Same to you.